So we chose for this EHA-EBMT joint session one topic that is of a special interest to all hematologists, which is the kind of the positioning of the older version or the initial version of cellular therapy in the CAR-T cell era. And we picked up the two diseases where CAR-Ts have made a real difference, which are multiple myeloma and lymphoma. We had two excellent speakers, Hermann Heinzele from Germany, discussing the role of CAR-Ts and the role of stem cell transplantation in the era of CAR-T, indicating the excellent results in terms of overall response rate, complete remission rate, and also promising progression-free survival with CAR-T in patients with multiply relapse multiple myeloma, and how CAR-Ts are moving even to the first line of therapy, always, at least for the time being, in the setting of prospective clinical trials. And the introduction of CAR-Ts has been one of the multiple reasons why the role of allogeneic stem cell transplantation in multiple myeloma has significantly decreased. Autotransplant is still the standard of care for those patients that are transplant eligible as consolidation strategy in first line. But of course, we will have to wait until we have the results of these prospective clinical trials with CAR-T that are challenging autologous stem cell transplantation in those patients that are transplant eligible. So the second topic was basically focused on lymphomas, and it was given by Catherine Thieblemont from France. And Catherine discussed the role of CAR-Ts and bispecifics, and also of stem cell transplantation, basically in diffuse large B, in follicular lymphoma, and in mantle cell lymphoma. Probably the best two examples on how stem cell transplantation has been modified by the introduction of CAR-T bispecifics, and of course other new or not so new treatment strategies are diffuse large B and follicular lymphoma. In diffuse large B-cell lymphoma, allogeneic stem cell transplantation has significantly decreased over the last years, and it's eventually considered in a specific population of patients relapsing after CAR-T. CAR-Ts have moved to the second line, and autologous stem cell transplantation is not the standard of care anymore in those patients with primary refractory disease and in patients with early relapse. And here the standard of care are CAR-T. Basically, the two constructs that demonstrated positive results in the phase 3 prospective clinical trials, while autologous stem cell transplantation is still the standard of care for patients with late relapses. We will see in the future potential results of CAR-Ts being used in first-line treatment for those patients with high-risk diffuse large B-cell lymphoma. And finally, moving to follicular lymphoma, the role of stem cell transplantation is less and less clear over time. The fact is that the numbers of transplants, both autotransplant and allotransplant in follicular lymphoma, have decreased significantly over the last few years. Following the data of the EBMT registry, we have very good results with bispecifics and with CAR-Ts, and probably if we have to sequence these treatment strategies, in many cases, probably bispecific monoclonal antibody would be favored before CAR-T, as opposed to what happens with diffuse large B-cell lymphoma, where bispecific monoclonal antibodies are being favored in those patients that fail CAR-T cell therapy.